Hello, thank you so much for joining us today. We have Dr. Mary McGann. She is a board certified oncology pharmacist working the outpatient hematological stem cell transplant and cellular therapy clinic at the Medical University of South Carolina's Hollings Cancer Center. Prior to that, she completed a PGY1 and a PGY2 oncology pharmacy residency at the University of California, San Diego Health. She completed her PharmD at South Carolina College of Pharmacy MUSC campus in Charleston. She's originally from Pennsylvania. Today, she's going to be talking to us about the use of thrombopoietin agonists for poor graft function, post-allogeneic transplant, and for CAR T cytopenias. I'll turn it over to Mary. Thank you so much for being here.
Thank you. Thank you for having me. I'm excited to talk about this kind of controversial topic today and just go over the data that is available and kind of also looking at it from a pharmacist perspective, things to think about. I do have disclosure, and then I will be talking about a lot of off-label use of medications during this. For our objectives, we will describe the incidence and proposed etiology of poor graft function post-allogeneic stem cell transplant and cytopenias post-CAR T cell therapy. And then we'll examine the management of this poor graft function post-transplant with thrombopoietin receptor agonists, and then in the CAR T setting, CAR T cell therapy cytopenias, and managing those with TPO agonists. Since it's kind of a lot of information to cover, I'm going to start talking about thrombopoietin as itself and the receptor, and then the FDA-approved agents to target this pathway. Then we'll go into the transplant portion of this and talk about management with TPO agonists, and then CAR T cell therapy cytopenias and the role of TPO agonists. So starting with thrombopoietin, TPO is a potent cytokine that physiologically regulates platelet production. It's produced continuously in the liver and other organs, and then it travels via the bloodstream to the bone marrow, where it promotes the early emergence of numerous hematopoietic lineages. Regulation of TPO is thought to be a pretty complex process, but looking at this more simplified pathway here, we see that native TPO binds to the extracellular domain of the TPO receptor. This then leads to a change in the configuration, which activates the JAK-STAT pathway, and then this signaling cascade stimulates the proliferation and maturation of megakaryocytes while inhibiting their apoptosis as well, so ultimately leading to an increase in platelet counts. When we look at thrombopoietin receptor agonists, they mimic native TPO by binding to the extracellular domain, like you can see the ramiplostim at the top here, or the transmembrane region of the TPO receptor, like eltrombopag, which is the purple small peptide, and avatrombopag, the orange one. This then causes a change in configuration and activation of this whole pathway that we just talked about. A benefit of TPO agonists is that they do not bind to the same site on the TPO receptor, which helps prevent competitive binding. There's this hypothesis that TPO agonists may have a role in hematopoietic recovery in single, bi, and tri-lineage cytopenias, so not just thrombocytopenia. And the thought with this is because like we talked about in the pathway, it can help promote emergence of early hematopoietic stem cells and other cell lines, so boosting production of them as well. The rationale for using TPO agonists in patients with refractory thrombocytopenia, post-allo transplant, and post-CAR T is that there's already impaired thrombopoiesis in the bone marrow, or there's accelerated peripheral platelet destruction. So stimulating this pathway can help increase the platelet production and also help lead or decrease the apoptosis happening. For completeness sake, I did want to just quickly touch on first generation thrombopoietin agents. You'll probably see you don't really recognize these and you don't see these in clinical practice much anymore. But when you do a deep dive on this topic, they do come up and there's some older trials. So I just wanted to mention them. We first had recombinant human TPO, which was derived from hamsters, and this encompasses the complete native human amino acid sequence. So there were small trials showing a benefit, The largest ones really showed no benefit outside of aplastic anemia and MDS, and this is not FDA approved in the United States. Then there was a pegylated human recombinant megakaryocyte growth factor. This also in early small studies showed promise, but the development of neutralizing antibodies, since it is human derived, and severe thrombocytopenia in 8% of patients from this led to discontinuation of all the trials that were in the US and kind of internationally as well. Last, we have oprelvecin, which is a recombinant human interleukin-2 analog. This is FDA approved for the prevention of chemo-induced thrombocytopenia in patients with non-myeloid malignancies, but the cost and the high adverse events led the manufacturer to stop producing this in the United States and not available in many other countries either. The FDA, although it's not available, the FDA does mention that they don't recommend using it following myeloablative chemotherapy due to the increased rates of adverse effects like edema, bleeding, hypotension, tachycardia, and some fatal side effects that were seen in post-marketing. So in general, we're not really going to talk about these anymore, but just so you know, they're out there. They have considerable severe adverse events, and the risk of neutralizing antibodies with these first generation is pretty concerning. And so they're not really utilized anymore. Which moves on to our second generation TPO agonists. So these are short peptide sequences that serve as analogs that activate the TPO receptor through that pathway we talked about. They have no sequence homology with TPO, so that eliminates the dilemma of autoantibodies being formed to the endogenous TPO. Here we have listed the current FDA-approved TPO receptor agonists on the market. We have eltrombopag, avatrombopag, lusotrombopag, and romiplastim. You can see the FDA-approved indications here are mostly aplastic anemia, immune thrombocytopenia, thrombocytopenia related to hepatitis. So like I said, we'll be talking about a lot off-label because nothing is really FDA-approved for thrombocytopenia post-transplant at this time. As a pharmacist, always got to talk about some pharmaceutical considerations and dosing and things like that. So the first three are oral, tablets, or capsule formulations taken once a day, while romiplastim is a subcutaneous formulation dosed weekly. For your reference, these are the FDA-approved dosing as well. Generally, you start at lower doses and then every 1 to 2 weeks increasing up to maximum doses based on the platelet response. Eltrombopag is really the most utilized TPO agonist. That's where the majority of the data we'll talk about is with, but it does have some considerations when we are prescribing this. It has drug interactions with polyvalent cations, so it needs to be separated from them. It should be taken on an empty stomach to help with absorption. And then if you have patients with East Asian ancestry, you should start at lower doses. On the other hand, we have avatrombopag, which is a newer TPO mimetic, and it's 3 times more potent than eltrombopag. So kind of starting to see more studies with this medication. It's mostly eliminated through the gut, so indicating that it's almost free from the signal for hepatotoxicity that we're concerned about with eltrombopag typically. It does not require any administration or dietary, well, it does require dietary. You should take it with food to help with absorption, but no other drug interactions, except if they have CYP3A4 inhibitors or inducers to consider with that. So both of those agents kind of need to think about from a pharmacist perspective if prescribing. The lusotrombopag is really just indicated for prior to procedures to boost platelet counts. So while it's FDA approved for thrombocytopenia, there haven't been studies with this in the post-transplant setting. And then romiplastim, the sub-Q formulation, has a benefit in case the patient wants to not take as many pills or you want to ensure compliance. So there are some studies with this as well, and it's dosed once a week and then increased weekly up to the 10 micrograms per kilogram, but also luckily don't have to worry about those drug interactions or taking with food or not with that. Side effects, this is mostly with eltrombopag, different the different TPO agonists kind of have different ones like we just talked about. But L-Tronopag, like I said, the main thing we think about is hepatotoxicity. This can happen in up to 10% of patients. So there are recommendations to monitor liver function tests prior to starting it and then every 2 to 4 weeks after. Luckily, in this post-transplant setting, especially if they're still struggling with cytopenias, probably seeing them that frequently, so it doesn't really add any lab work to them. We should be concerned too about a rebound thrombocytopenia when discontinued. So it should be tapered off and not just withdrawn abruptly. There have been shown to have transient decreases lower than even the initial baseline platelet count in about 10% of patients when it was taken off. And then with any medication we're using to boost platelet counts, also concerns that these can cause thromboembolic complications once those platelet counts get too high. So also some guidance on if the platelets do recover, how to come off of that and not just leaving it on and boosting the platelets to an excessive amount. And then based on this mechanism as well, there is a concern for the development or progression of reticulin fiber deposition within the bone marrow. And so just something to think about when you're having bone marrows, to look for disease surveillance. If you see more fiber deposition could be due to L-Tronopag. And then also a theoretical concern for an increased risk of hematologic malignancies, because similar to using like growth factor in a myeloid setting, concern that you're stimulating a malignant clone through this pathway. But when you look kind of at the specific data, these are mostly theoretical concerns. Rates of these in trials and even bigger trials outside of the post-transplant setting have seen relatively low rates of these types of adverse events. And then the package inserts for all these medications have great tables on how to adjust it based on platelet counts, how to adjust it based on LFTs too. So if you run into that, would just recommend looking into those. So now talking about poor graft function post-allogeneic stem cell transplant. So when looking at this, there's a lot of different definitions for low counts post-transplant, really depending on what cell line it is and the timing post-transplant. So I just wanted to get the definitions out here so that when we look at trials and they have different they're using these different ones, we know the definitions. So delayed platelet engraftment is really platelets less than 20,000 beyond day 35 post-transplant. And then secondary failure of platelet recovery is thrombocytopenia that develops after an initial platelet engraftment. So the platelets come up to an acceptable amount above the 20,000, and then after that they decrease, and you rule out if it's graft rejection or relapse. It's just kind of thrombocytopenia. Then prolonged isolated thrombocytopenia is platelets less than 20,000 or a platelet transfusion needed 60 days beyond post-transplant despite engraftment of other cell lines. So just the platelets that are not recovering, 2 months post-transplant. Primary graft failure is failure to achieve initial neutrophil engraftment by day 28 to 30. Kind of irrespective of the platelets. And then poor graft function is really looking at the platelets and the neutrophils. And if you're having issues needing transfusions, needing growth factor support beyond the 28 days post-transplant, but you have acceptable donor chimerism. So you have the graft there, it's just not functioning as well as expected. I thought this was a great figure to kind of show those definitions in a visual format. So we have the platelet count on the y-axis and the days post-transplant on this x-axis, and day 0 is stem cell infusion. So as expected, the first 2 weeks, the counts are plummeting, they're neutropenic, they're having mucositis, concern for SOS. But then around the 2-week mark, into the 3 to 4 week mark, the counts are recovering. So the dotted line here, the green dotted line, is normal platelet engraftment. So they drop, and then around the 2-week mark, they start increasing, and then about day 30, they should be, above 20, and then just continuing to increase. But in primary isolated thrombocytopenia, they drop, but then they really never go back up. They just stay down for indeterminate amount of time. And then the second Secondary failure of platelet recovery is this red line. They go down, they recover as expected around the 3-week mark, but then after that, at some time point, they decrease again and kind of stay low. And so there's a lot of different reasons that this can occur, kind of things we think about: viral infections, graft versus host disease, chronic immunosuppression, but many times it's kind of can be multifactorial as well. So poor graft function post-transplant is a really serious complication, and there isn't any standardized treatment. 10 to 20% of patients will have this prolonged isolated thrombocytopenia. Up to 25% will have poor graft function, and then 40% will have up to 40% will have a secondary failure of platelet recovery. So it is, more common than we kind of tend to think sometimes. So I'm sure any transplant, pharmacists and providers do run into this. And it does have a big impact on our patients, on the healthcare system, because we're concerned for additional complications. If it's poor graft function, that's affecting the neutrophils as well, concerned about infections, bleeding with the low platelets, and for patients, a big reduction in quality of life because they're probably needing transfusions, weekly, if not a couple of times a week, which is more than expected kind of in the later stages of transplant. It also increases morbidity and mortality and is a bigger increased burden on the healthcare system. You're having to see these patients more frequently, do more extensive workups. And so this is kind of a really serious complication. And it's understandable that, trying to explore how we can help boost these bone marrow and the platelet production to kind of help lessen this whole impact. Risk factors, there's a lot you can find out there. And as we all know, transplants are pretty complicated and every transplant's a little bit different. So it's hard to really nail down specific risk factors, but we know that things like unrelated donor, grade 2 to 4 acute graft versus host disease, viral infections, valganciclovir, ganciclovir medications like that, renal or liver dysfunction and conditioning regimens can increase the risk of developing more prolonged cytopenias post-transplant. When you start having kind of poor graft function, including the neutrophils and the platelets, really I'm thinking more about the platelets here, but you want to kind of work up to see what is the issue. Is it impaired platelet production? The bone marrow is not producing enough platelets, or is the bone marrow producing platelets, but they're being peripherally destroyed? And I won't get into kind of what labs or when to do a bone marrow, things like that. But for the providers, they're kind of working this up to determine this. And then, impaired platelet production more lends to us thinking it's from poor graft function, or it can be from viral infection or medication side effects. And then increased platelet destruction is more like a bacterial infection or an immune-mediated process. So kind of knowing where the issue is can help us determine the best way to manage it. So for poor graft function, we'll talk about TPO agonists a lot here. There is data about using stem cell boost to kind of help boost the bone marrow, viral infections, monitoring for these, supportive care, IVIG if it's indicated, medication side effects. We mentioned before, valganciclovir, ganciclovir, we know those really can beat up the marrow. Other things, Bactrim, I think everyone likes to point the finger at Bactrim. When you start having counts drop, at prophylactic doses, it's really less common, but at least in our practice, we typically still just pull it off because, these are complicated patients with a lot of things going on. And if we can eliminate, one area and say rule that out, then we will. And since we have other options for PJP prophylaxis. If there's increased platelet destruction, determining if that's due to an infection as well, and then treating that appropriately, or if it's more immune mediated, you can use rituximab, steroids, higher dose IVIG, or TPO agonists, again, like we'll talk about. So we know poor graft function post-transplant, decreases quality of life, is a big burden on the healthcare system. So what are some of our options specifically when looking at thrombocytopenia? We'll talk about the role of TPO agonists. Eltrombopag, like I said, is the one that's been most studied for post-transplant thrombocytopenia. There are over 20 retrospective reviews, a few clinical trials that we'll dive further into, and then a ton of case reports out there. So I'll also kind of guide you to this El Said reference here. This is a big review done just last year now. That's really comprehensive and kind of pulls out every single small study on Eltrombopag. So if ever kind of interested in that, I would recommend looking at that reference. But I tried to just pull out kind of the bigger retrospective reviews, and then also, the prospective clinical trials. So starting with Bento and colleagues, this was a retrospective review with 86 patients. 6 had primary isolated thrombocytopenia, and 71 had secondary failure of platelet recovery. This utilized Eltrombopag and Romiplastin, but more in the Eltrombopag arm. Again, ranging doses, typically starting low, titrating up. And these were started at a median of 1 month post-transplant. For platelet recovery, 72% had platelet recovery in the secondary failure group versus 67% in the primary isolated group. So generally seemed to work well. The primary isolated thrombocytopenia group took longer to respond, 3 months versus 2 months. And then looking at other cell lines, patients that had neutropenia initially, majority of them also had a neutrophil response. So potentially kind of showing that it can help in other cell lines besides just platelets. Median duration of the Eltrombopag was about 2 months. And they saw 2% had a grade 3 to 4 liver abnormalities. Although, this was shortly post-transplant, it was hard to determine if that was specifically from Eltrombopag. Next, Jan and colleagues was 34 patients, another retrospective review looking at the post-haplo setting with peripheral blood. So we know haplo kind of can have struggling counts post-transplant. 7 were primary isolated thrombocytopenia, 27 secondary failure of platelet recovery. These were all utilizing Eltrombopag, starting low, titrating up. And this one starting a little bit later at a median of 95 days. Cumulative incidence of platelets above 20,000 was 72% and above 50, 61%. So kind of similar rates to that last trial as well. The median time to platelets above 50 was 23 days, but a huge range you can see there. 86% of the people that did respond were able to taper off with stable counts, which is a great sign. And then they did see that the people that responded had a higher proportion of adequate megakaryocytes in the marrow at baseline. So not always is there a bone marrow done prior to initiating a medication like this, but in this study of those that did, they could see that those that had more megakaryocytes in there responded better, kind of showing that the bone marrow is working and megakaryocytes are producing, and that these TPO agonists can kind of just help stimulate that pathway that's already working. It's just a little sluggish. And then no grade 3, 4 toxicities in this review. And then lastly, we have Juven and colleagues, 48 patients, 30 had delayed platelet recovery, 18 secondary failure. Eltrombopag again started 3 or 2 months post-transplant. 23 of these 48 patients responded. The cumulative incidence of platelet recovery was about half the patients, 38% in the delayed platelet group versus 50% in the secondary failure for platelet recovery. And similar, this study also showed that patients that had adequate megakaryocytes in the marrow at baseline had a much better response. 77% of those had a response versus 23 in the other group. So potentially a way to signal or predict a response for these therapies. And again, pretty safe, no Eltrombopag related toxicities were noted. Now I wanted to pull out a prospective randomized controlled trial by Ahmed and colleagues in 2021. This looked at people with post-transplant, a wide variety of types of transplants with bone marrow or peripheral grafts, and this was 60 patients. If patients had platelets less than 20 for 7 days, were transfusion dependent, but did have neutrophil recovery at or beyond day 35 post-transplant, they could be enrolled in this trial. 42% of patients got eltrombopag and 18 got placebo, and eltrombopag was titrated up, started at 50 milligrams daily and then every 2 weeks until it reached 150 milligrams. And then it was planned to be continued for 8 weeks. When we look at the efficacy here, the primary outcome was platelets above 30,000 at day 57, which is kind of an arbitrary decision to make that, their endpoint. But they saw that 30%, 36% in the eltrombopag arm versus 28% in the placebo arm had this platelet recovery, and this was not statistically significant between the groups. But when they looked at platelets above 50 instead of 30 at day 57, there was a benefit, and 21% had that in the eltrombopag arm versus 0 in the placebo arm. So kind of interesting, noting that, more patients got above the 50, but at the 30 mark, it was not significant. On the right here is just every patient kind of noted and the platelet count. The blue are eltrombopag, the pink is placebo. So you can kind of just see a lot of variety between these patients. A big limitation of this prospective trial was suboptimal compliance. So only 62% of patients actually completed the 8 weeks of therapy, and people discontinued due to a perceived lack of efficacy, some side effects. But when they looked between the two groups, it was similar in the amount that were not compliant and why they discontinued. So unfortunately, that really limits this already very small sample size that patients did not, do the whole treatment intended. Both arms had similar survival, progression-free survival, non-relapse mortality. Safety-wise, they did see for grade 3 or higher rates of hyperbilirubinemia in the eltrombopag arm, 6 patients versus just 1 in the placebo arm. So this was statistically significant. So again, something to be aware of when utilizing eltrombopag. And then the same group, Ahmed and colleagues in 2024 designed another prospective phase 2 trial. This was specifically looking at haplotransplants with a bone marrow graft. So these are patients we know have cytopenic issues post-transplant. This was a little different type of setup. They did eltrombopag 300 milligrams daily, which it has been studied and shown to be safe in other things, which is how they got this dose, but still a pretty high dose. And it was started preventatively on day +5 and then compared to a placebo group. And then the eltrombopag was continued for at least 35 days. So the thought here really like boosting platelet engraftment from the beginning. Their primary outcome was platelet engraftment by day 60, and they saw that in 74% of patients in the eltrombopag group versus 50% in the control group, which was statistically significant. The median time to platelet recovery above 20,000 was 29 days versus 31 days. So this was statistically significant, although clinically, I'm not sure how much 2 days is really significant. And then they also looked at the cumulative incidence of platelet recovery over 20,000 and 50,000. This figure on the right is the graph of over 20,000, and you can see that 90% in the eltrombopag arm versus 68 in the placebo arm had cumulative incidence above 20,000. So that was also significant. And then but this one, above 50,000, the groups were pretty similar, 77% versus 64%. Similar again between groups was survival, progression-free survival, GVHD rate, non-relapse mortality, neutrophil engraftment. But I thought it was interesting that between the groups, the number of platelet transfusions was similar. So, a lot of this is just looking at platelet counts, numbers on a lab sheet. But what's really the clinical implication if they're needing the same number of platelet transfusions between them? So I thought that was interesting, and not all of the studies have pulled that out and counted that. Looking at safety in this study, concern using such high doses of eltrombopag and right in the kind of acute engraftment phase, but they saw no grade 3 to 4 adverse events, no patients discontinued due to side effects, and then you see the potential toxicities associated, not too significant here, pain, bili increase, diarrhea, headache. Now we'll get into romiplastum. Like I said, this sub-Q formulation has less data behind it, but there was this prospective single-arm trial of 24 patients. 10 had delayed platelet engraftment, 26 had secondary failure platelet recovery. They used the weekly dosing starting at 1, increasing up to 10. And this was initiated at a median of 85 days post-transplant and then continued for 12 weeks. Efficacy was 75% of the patients responded with platelets over 50,000. Median time to response was 45 days. 16 of these patients had a durable response, 16 of the 18. So that's good that it increased and then kind of remained stable. And then looking at other blood counts, a lot of patients that had baseline issues with hemoglobin and neutropenia did have an increase in those as well. Again, potentially showing that it can help other cell lines. And then there were no clinically significant adverse events. And then looking at avatrombopag, this is our newest TPO agonist. There was this retrospective review of 61 patients, 35 had delayed platelet recovery, 26 secondary failure platelet recovery. They started at 20 milligrams once a day and then titrated up to 60. And again, initiated around the kind of 1 to 2 month mark. Overall response rate was defined as platelets over 20,000 for more than 7 days. That was seen in 70% of the patients. Of the responders, 60% were in the delayed platelet group, 40% in the secondary failure group. Median time to this was 3 weeks post-initiation. And then they also looked at platelets over 50,000 for 7 days. This was lower, about 40% of patients. They did see, when they looked at subgroup analysis, looking at the megakaryocytes at baseline, that is this figure A over here. They saw that having adequate number of megakaryocytes, similar as we've seen in a couple of trials, was a predictor of a response pretty significantly here. They also looked at non-bone marrow failure and bone marrow failure syndrome transplants. So a lot of the other trials are just looking kind of at AML, ALL, type of patient population. This one did include patients that had MDS, aplastic anemia, myelofibrosis. And when they pulled them out, they saw that those types of disease states performed worse and had less of a response to the TPO agonist. And so this maybe is showing that really it's the underlying disease state and the bone marrow at baseline kind of not responding as well to the TPO agonist post-transplant. At 4 months post the initiation, about half patients were able to withdraw and didn't have kind of a rebound thrombocytopenia, which is great to see. And then really no clinically significant side effects were seen. So I think we'll probably start seeing more types of reviews with avatrombopag. This is just a summary of those 4 trials I looked at. I'm not going to go over them again, but I think just kind of a good reference to look back on. So in general, when we think about TPO agonists post-transplant, there's really limited prospective controlled trials. There's a ton of small studies out there that demonstrate reasonable efficacy, tolerable safety profile, efficacy, 30 to 70%. But most of these studies are not controlled. And so we can't tell if this is just spontaneous count recovery post-transplant, which we see, or if it's really due to the TPO agonists. There is, from what we've seen, it appears it can help improve tri-lineage hematopoiesis. So that's just something to keep in mind if you have people struggling with thrombocytopenia and other neutropenia and anemia. There is no standardization out there on dosing, timing of initiation, duration of therapy. As you saw, all those trials had very variable, start dates, durations, and dosing as well. And then this baseline adequate megakaryocytes, I think, is an interesting thing to think about, seeing if maybe we can use that as a predictor and a way to decide who will best respond to this type of therapy, because a lot of those trials looking in subgroup analyses did see that that was a predictor. Going through our 3 really TPO agonists that we have the data with, eltrombopag is the oral formulation most studied in this context. Then we have romiplostim, the sub-Q formulation, less convenient because it's sub-Q, but In some patients where you're worried about compliance or they just take a ton of pills, it could be helpful for that setting. And then avatrombopag is the newer one, works similarly to L-trombopag, but thought to be much more potent and theoretically less hepatotoxic. So I think, we'll start seeing more information with that medication. So now let's get into CAR T cell therapy and cytopenias we see post this. So, everyone with CAR T thinks about CRS, ICANS, those types of kind of well talked about things, but cytopenias is actually the most common side effect associated with CAR T. So I think as we've gotten a lot more experience with CAR T over the years, we've learned a lot more. And, now that we're feeling good about managing CRS and ICANS, we're starting to see more long-term effects of CAR T and the impact of that. And a big part of that is cytopenias. 25% of patients will just have this transient self-resolving cytopenia that's really just due to the lymphodepleting, and then 1 to 2 weeks after that, their counts recover and they stay recovered. But 50% of patients will have this biphasic cytopenia. So they have that decrease, their counts recover, and then, beyond the 3-week mark, their counts start decreasing again. And, the initial one is from the lymphodepleting, and then the second kind of lull is really due to CAR T cell therapy and these other things we'll talk about. And then 25% of people do have an aplastic phenotype with prolonged cytopenia. So really beyond like a 3-month mark, they're just having very poor counts. And this has a really big impact. Similarly to transplant, we're worried about infections and bleeding, big reduction in quality of life. I think, a lot of patients hear CAR T, they know it will be really intensive for the first few weeks and first month, but they kind of expect that they'll be done after that. And so when you have lingering cytopenias, it's really just a big burden on patients to having to come back more frequently, and the healthcare system having to set up transfusions and things like that. And there is data that having low counts post-CAR T also increases morbidity and mortality. And so I think this is something we're starting to recognize a lot more and try to figure out ways to help prevent this. In the pivotal trials that got all these CAR T cell therapies approved, everyone mentioned thrombocytopenia and cytopenias in the early stages as expected, but they didn't always report like how long the thrombocytopenias and cytopenias lasted. But from some of these that did, you can see, up to 40% of patients were still dealing with really severe thrombocytopenia post-CAR T up to 3 months. And then this is really confirmed with a lot of real world studies out there right now, kind of echoing that this can be an issue. When we think about risk factors for cytopenias post-CAR T, there's a lot of things thinking about the patient's factors, age and sex, the disease-related features, what's their disease burden going into it, what's their underlying disease, how much prior therapy have they had, how beat up is their bone marrow prior to this. And then these ones bolded and in orange are the ones that have been shown to be independent risk factors for cytopenias post-CAR T. So they have a baseline marrow status. If they have marrow disease initially, this is a risk factor, because really then we assume that the CAR Ts are also going to go into the bone marrow and start killing some of those cells as well. And then pre-existing cytopenias, if even before CAR T they're struggling with the counts, then we kind of expect that post it's going to be a challenge as well. And then baseline inflammatory status to increased serum ferritin prior to lymphodepleting has been shown as a risk factor, again, related to kind of like their disease burden. And then the CAR T cell products, what type of product it is, what's the lymphodepleting, their CRS and things like that. We have seen that CD28 products, which are thought to be, cause more toxicities, peak higher in the body, those are related to more prolonged cytopenia. So medications like the Axicell and Tecardis. So the EHA and EBMT has recently developed a grading system for hematotoxicity after CAR T called immune effector cell-associated hematotoxicity. And this grading is based on neutrophil count and the timeline from CAR T. So really recognizing that this is a very different process than like post-transplant cytopenias when we think about kind of like the timeline and things like that. So just wanted to put this here as a reference. And then they also developed a CAR hematotox model looking at baseline platelets, ANC, hemoglobin, inflammatory status prior to CAR T to try to predict who will have these prolonged cytopenias. And you're given a score of 0, 1, or 2 based on each of those values. Low risk is 0 to 1 score, and basically just showing that they will not have as big of a depth of neutropenia or a duration, and their risk of having aplastic phenotype is really, less than 5%. But if they have a score of 2 to 7, then they're at much more high risk of having cytopenias post-CAR T with aplastic phenotype up to 47%, severe infections up to 40%. So this is a helpful kind of tool. It's been recently developed, so we're not really sure how best to incorporate what to do with this information, but I think that will grow with time. I will note that this has a really good negative predictive value. So if you're low risk, it's a pretty good sign that you won't struggle with the cytopenias. But not everybody that is categorized as high risk will, have this aplastic phenotype and things like that. Now looking at the role of TPO agonists. So similar to post-transplant, it's really hard just watching these people suffer with low blood counts and all the issues with that. And so, trying to think what we can do to help target and improve that. And so, we use TPO agonists in transplant. It was kind of natural that then it was starting to be explored post-CAR T. There's a lot less data out there post-CAR T, so I'm just going to pull out kind of the 3 biggest retrospective reviews that we have. This one from Wesson and colleagues reviewed 185 patients post a variety of CAR T products. This was a multi-institution review, so 23% of those 185 patients received a TPO agonist, different doses of eltrombopag, but really titrated up. And then they compared this to the non-eltrombopag group. Again, because it was multi-institution, they didn't have a real standard for how or when eltrombopag was started, but in general, it was kind of grade 4 thrombocytopenia beyond the 3 to 4 week mark. They did see that those who got eltrombopag were more likely to have leukopenia, thrombocytopenia at the lymphodepletion, or have received bridging therapy or had any grade serous. So those are kind of the risk factors that they saw for having more prolonged thrombocytopenia. Median initiation time was 33 days post-CAR T, and then the duration about 2 months. But you can see a wide variety and range there. So at day 90, they saw that grade 3 cytopenias, were dealing with any cell line was lower in the eltrombopag group, 17 versus 31%. And then at the 6-month mark, 94% of patients did have count recovery, which is a good sign. But that was not different between the eltrombopag and non-eltrombopag group. Safety-wise, they specifically looked at bleeding and thrombosis because those are the concerns, and did not see any differences between the groups. Next, we have Drilla and colleagues, who was a retrospective review of 71 patients with mantle cell lymphoma and diffuse large B-cell lymphoma. 15% of these received TPO agonists, eltrombopag for 10 patients. 1 patient got romiplastim, initiated about 3 weeks post-CAR T, and then, given for 3 months. Here they have listed every patient, and the day 0 is not CAR T day 0, it's the day that the TPO agonist was initiated. And you can kind of see just a wide variety. Some patients responding really quickly, like the red and the green we see here, and then other people just maybe sluggishly increasing over time. They saw that the median time to platelet transfusion independence was 17 days, and the median time to platelet recovery was 46 months. Then at the 6-month mark, only 1 patient was still platelet transfusion dependent. So seemed to work in the majority of patients and no clinically significant side effects. Here, I thought this was an interesting figure because it looks at the number of platelet transfusions. So the black dot on the left is the CAR T cell infusion. All the red lines are platelet transfusions. And then, the dotted line in the middle is when the TPO agonist was started. So you can kind of see, again, a wide variety. Some people, it was a drastic decrease as soon as the TPO was initiated. They really had less transfusions. Some, it took some time, but I thought this was a nice visual. And this also shows, all these patients, you can most of them, you can see when their last platelet transfusion was, but this number on the right-hand side is what day they stopped the TPO agonist. So that's another big thing. No one really knows when to stop it. You're kind of scared if it's working to take it off and have their counts plummet. And you can see here, majority of these people continued much longer than, while they were transfusion independent. And then lastly, we have Bayer, Katz, and colleagues looking at 93% of patients with lymphoma. About 7% received TPO agonists, L-Thrombopoietin, or romiplastim, or both. The both was really just an insurance issue. And it was started about 43 days post-transplant. And then they did have a plan of once the platelets got above 50, they tapered off over 2 weeks. The median time to resolution of cytopenias, which we'll see in the figures here, platelets 27 days, and then they looked at the other blood cell lines too, anemia 22 days, neutropenia about 30 days. And resolution of all cytopenias was seen in 5 of the 6 patients, so seemed to work pretty well. One patient did have transaminitis. They stopped the medication and then it resolved and they restarted it and they did not have issues with the liver function after that. So that's a good thing to know. You can consider trialing again post liver issues. So again, this is just a summary of those 3 trials I talked about for your reference. And in general, for TPO agonist post-CAR T cell infusion, it appears safe, maybe efficacious, similar to post-transplant. We don't know anything about the best way to when to start it, what dosing, how long to take it. The majority of the data is with L-Thrombopoietin over romiplastim. But the biggest limitation is that this is all retrospective data. And while they tried to use a comparator arm, you really can't conclude if this is just spontaneous count recovery that we'll see post-CAR T, or this is due to the medication. The EHA and EBMT does have kind of recommendations out there for cytopenias post-CAR T, and for platelets and TPO agonists, they recommend a practice that's parallel to transplant. So considering it for prolonged thrombocytopenia requiring platelet transfusions beyond day 30, potential dosing can be, starting at the 50 to 75 milligram dosing and then increasing to the 150. And then again, for duration, it's all over the place. I think looking at these studies, most of the people that had a response in 1 to 2 months. And so if patients are on it beyond that time and not seeing a benefit, I think it's reasonable to try to take it off. And, sometimes less is more. These patients are already generally taking a lot of medications. So in conclusion, looking at poor graft function, cytopenias, post-transplant, post-CAR T cell therapy, really, I'm sad to not be able to give, general recommendations and standardize this, but it's kind of all over the place. Looking at poor graft function and cytopenias, the incidence also ranges, probably underreported, but can be up to 40% with varying onsets. Risk factors thought to be infection, GVHD, med side effects, immune-mediated platelet destruction related to conditioning regimens. And then post-CAR T, again, we're learning more about this, but incidence of late thrombocytopenia can be up to 40% as well. Risk factors for that, we have some kind of ones that have been determined to be independent risk factors, such as marrow disease involvement, baseline elevated inflammatory status, CD28 CAR T products. And we know that post-transplant and post-CAR T, these cytopenias increase morbidity, mortality, quality of life, and healthcare resource utilization. So definitely an area that people are researching to try to improve all of this. Looking at management, there's no standard protocol for using TPO agonist post-transplant CAR T. talking about timing and dosing. But post-transplant, there's a lot of data out there. It's all just kind of limited and retrospective, and it can have efficacy of 40 to 70%. But again, there haven't been great randomized controlled trials. So like we talked about, really hard to determine if this is the true effect of this intervention or just spontaneous recovery that we'll see. So we really need some future prospective trials exploring also clinically relevant outcomes like bleeding events, transfusion requirements, not just, platelet numbers, and then also trying to identify specific populations that could benefit. Some of those studies looking at the baseline megakaryocytes, I think, are interesting, and getting more robust data like that would be helpful. And then TPO agonist use post-CAR T is really less well studied, and we're kind of just extrapolating from the transplant setting. So the practice seems to mirror that. But in general, at least with all of this data, we haven't seen any really concerning toxicities, and it does appear safe to use in this setting. So that is all I had today, but I'm happy to take any questions.
Thanks so much, Mary. We really appreciate it. We do have some questions here in the chat, and I'll go ahead and just kind of get started with a few of them. One of the first ones is, any thoughts for the reason of low efficacy of the ATPOR in individuals after an allo transplant? Maybe the number of megakaryocytes, or maybe a megakaryocyte defect?
Yes, I think that's a great question, trying to figure out any little population that we can kind of predict response. So in that one avatrombopag study, it did show, kind of looking at baseline megakaryocytes, and saw that people that did not have adequate megakaryocytes in the bone marrow at baseline did not respond as well. That was one small study. So I think hopefully we'll get more information in the future. But if you kind of have a recent bone marrow and you can look at that to try to guide if you think it will help or not, I think that's definitely reasonable, and mechanistically also makes sense.
Thank you. Do you have a potential explanation for the relationship between excessive platelet destruction and the administration of ATPOR?
Yes, so I saw this come in, and I was kind of looking into it a bit more too, and I did find kind of an article that explains this mechanism very in depth. So I'll put that in the chat. Generally, kind of as we did with everything, it's extrapolating from the ITP setting. And in that setting, generally there's platelet destruction and impaired platelet production. So the TPO we're thinking is really helping with increasing the megakaryocytes and platelet production. But I guess in some studies, it has shown that kind of through the whole cascade, it is helping kind of reduce the cascade that's causing platelet destruction as well. So hopefully helping on both sides of that.
Great. A couple questions, potentially like a preemptive TPO agonist during ganciclovir therapy for CMV reactivation. Have you used any of that in your practice? I know I have not.
I haven't either. And I didn't see any data for that. I think, we hope the counts don't plummet. So as soon as they do, we generally add it on, but I've never seen kind of doing it when they still have adequate platelet counts.
Now that we do have multiple TPO kind of agonists on the market, and there's different ones, is there one that you think may be like a priority, or kind of something you would think about first?
Here in my practice, we typically use Eltrombopag just because it's an oral medication. So, a bit easier than getting authorization and having patients come in for Ramaplastum. Sometimes insurance dictates it, and that's how we decide. Avatrombopag is definitely a newer one, so I don't have as much experience with that, but I think the practice may be going that way as it's, more potent. And there are studies kind of that potentially it'll be more efficacious in the ITP setting. So it may go that way, but right now I feel like I have the most experience, and, the colleagues I work with Eltrombopag. So that's kind of what we tend to lean towards.
Us as well. And along the same lines with, is there ever a justification to change to a different agonist post potentially allo if you're not getting the response?
Yeah. There is in the ITP setting some info on changing to avatrombopag after L-trombopag or romiplastim and it having efficacy after not having a response. So I think that's definitely warranted. I haven't done that in the practice yet here, but I think something that is worth exploring.
If we, I think at one point talked about our TPOs were more of a third line therapy option. Any specifics that you would offer from like a first line and second line treatment options? Um, and then considering, I think we talked about the very gray area of what that question is, how do you stop them once you've kind of gotten to a platelet threshold where you feel safe enough? What have you seen in your practice for when it's okay to stop that? So twofold, what would be first and second line options, and then potentially how do you and when do you stop?
Regarding the third line, I might have misspoke there. Generally before we get to the TPO agonists, it's just supportive care, platelet transfusions. Um, we tend to go to TPO agonists prior to like exploring high dose IVIG unless we really feel like it's an immune mediated, ITP type process. Um, so we kind of do supportive care. And then if it's, intense platelet transfusion requirements, and follow up, and that will kind of explore TPO agonists after that. So it's kind of the first line like medication management that we go to. When to stop is, we debate that, and it depends kind of who I'm working with that day. Generally, once they start seeming, we generally start it if they're still platelet transfusion, so below 20. And then if they get above 50, we kind of start having the conversation. But some people still feel kind of nervous to pull it off, and then they might kind of backslide. So once it gets above 100, we really try to start pushing the like, I think they're tolerating or they're, it's kind of recovered and we should try pulling it off. Unless there's some cases where we've had counts drop with ruxolitinib if they have chronic graft-versus-host disease and they're still kind of borderline around 100, but we've decided to keep it on for the duration of the ruxolitinib therapy, kind of like a preemptive thing at that point. So we've seen that, but I think practice varies a lot.
Yeah, I think so too. It definitely will depend on how they're doing. A question about the risk of developing veno-occlusive disease when prescribing an ATPO, given thrombosis-inducing potential.
Yeah, and preparing for this, I didn't see any cases reported of VOD with TPO agonists, and generally, because this is more like prolonged thrombocytopenia, in the later stages of transplant, they're out of that, 21 days VOD risk. So it's not really ever generally being started while they're at high risk of VOD. And even the clot potential, I think that everyone gets worried about, but the cases are very small in the literature. So not a super prevalent side effect.
One of the questions about empagliflozin was about the lowest efficacious dose, and then similarly, what dose do you tend to start people on post-CAR T for thrombocytopenia?
Yes, we start at 75 and it's purely like pharmaceutical ease. If we start at the 50 and then we go to 100 and then we go to 150, generally we do try to get to the max dose. We kind of increase it every 2 weeks. And normally we aren't seeing a super quick, robust response. So we kind of just get to the 150 and then stay there for about a month or two. A lot of insurances, at least in the US, will only cover 30 pills or 60 pills. So if you start with 25s or 50s, you kind of get in a weird insurance won't cover it. And so we always just start at 75 and then we can just double it to 150 and it's less confusing for the patient. And we run into kind of less like prior auths, multiple prior auths being needed for a bunch of different dosing. But we have had a few patients that respond, at the 75 dose quickly, and we kind of just leave them there. But I would say the majority of the time we go to the 150 milligram dose. But maybe we just haven't given the lower dose enough time to see if it works. So not to say that it may not be efficacious.
I think that's probably a very variable practice based off of where you are and everything. But thank you so much, everyone, for joining us today. I hope you found this beneficial. Continue to log in for future presentations. Thank you so much, Mary.
Yeah, thank you for having me.